Bismillahirrahmanirrahim. Today we're going to discuss oral ulcerative lesions, specific topic which is recurrent Aphthous stomatitis or recurrent Aphthous ulcer. Recurrent Aphthous stomatitis is a disorder characterized by recurring ulcers confined to the oral mucosa in patients with no other signs of the disease. So here the disease is ulcer, and this ulcer is only presented in the oral cavity, an oral mucosa. So the patient will not complain of any other symptoms. Okay? And the diagnosis of this disease or ulceration is done by exclusion. Exclusion, since hematological deficiencies, immune disorder, and some connective tissue diseases, they have the same oral ulceration similar to the RAS or recurrent Aphthous stomatitis. In another definition, it's a painful, single or multiple, recurring. This is a very important option, which is recurring ulceration, commonly affected the non-keratinized oral mucosa. So I can find it on labial mucosa, buccal mucosa, floor of the mouth, and soft palate, okay, with no other signs of the disease. So the only complaint of patient will be about oral ulcerative or painful oral ulcer. Okay, the recurrent Aphthous ulceration is the most common painful oral mucosal disease. So one of the complaints that guide the patient to come to our dental clinic is oral ulcer, which is recurrent Aphthous ulceration. So the most common lesion after dental caries and periodontal disease. They are all painful conditions. The age. It may start at early age in the childhood, and moreover usually seen at teenagers and less frequent as patient enter the fourth decade. So um, although the patient is getting older, the lesion may be disappeared. So it may be disappeared or fade at the fifth or sixth decade of life. It's more seen at females, and we said at the definition that the oral ulcer commonly present as a solitary lesion limited to the non-keratinized mucosa. Rare occasions affect the keratinized mucosa. We will discuss the types, and one of the types of the recurrent Aphthous ulceration uh, prefer to occur on keratinized mucosa. Okay, what about the pathogenesis? Begin by prodrome up to 24 hours with tingling and burning sensation. The tingling and burning sensation occurred at the site where the lesion or the ulcer will develop later, followed by painful erythematous macule or papule, redness of the lesion, okay, surrounded by erythematous halo, and then this lesion will be blanched surface due to the necrotic epithelium exfoliation, and the sloughing occurs soon and the oral ulcer left behind. So the main complaint of the patient is pain, and the lesion can be occurred on uncomfortable side, so that it will interfere with the functions, okay, such as speaking, eating, and some symptoms may complicate the condition. Okay, so the location plays major role in the severity of the symptoms. Ulcers on the tongue also can be uncomfortable with the chewing and speaking, okay, interfere with functions in general. And the ulcers of the soft palate and esophagus interfere with the swallowing, or the patient will complain of discomfort and pain during swallowing, so they are acutely painful. Ingestion of the acidic food, beverage, and uh, may be uncomfortable too. So the patient with a recurrent onset, um, when the prodrome and tingling and sensation this start, the patient will be aware that he may develop the ulceration soon. Okay, in 1985, Hendrickson divided recurrent Aphthous ulceration into three forms. The most common form, okay, and the mildest one, which is minor Aphthous ulceration, about 80% of population with a recurrent ulceration, okay, will be minor. And 10% goes to major, and there is a form known as herpetiform of this ulceration, and there a new form added which is severe of this ulceration. Okay, about the minor of this ulceration, quick discussion. It's a small ulcer, less than 1 centimeter, and of course it's shallow in depth, and there is a erythematous halo, of course, and it's a regular. I can define it. Okay, it may be rounded, oval in shape, slightly raised ulcer, and the floor covered by grayish yellowish white fibrous exudate, as you can see at the picture, and the shape is related to the size. If it is found on the lip or cheek, it will be round in shape, and if it's in sulcus, may be elongated ulcer. The site, as we said, non-keratinized mucosa, and this may help you in the diagnosis. The number, it may be solitary, one ulcer only, or up to 6 ulcers. The chief complaint, of course, pain, later discomfort. Why pain at the first? Because of the destruction, and discomfort later because of destruction has already happened, but the granulation tissue and the membrane developed. Okay, healing within 10 to 14 days without a scar, and it can be occurred without treatment even. The recurrence, doctors classify the recurrency into frequent and infrequent. The frequent, that the patient complaining or from this recurrent status every month or every few months, and the infrequent, twice or one every year or every several years. In few patients, and this is may be related to the medically compromised or immunocompromised patients, there is no free period between attacks, so the new set of ulcers overlap previous group. The previous group healed or about to heal, then the new set of ulcer developed. About the major size is large size, more than 1 centimeter, and it's deep, can be deeper into connective tissue, minor salivary glands, and facial muscles. The margins are raised, and here, as you can see, this ulcer, it's irregular borders, shiny and erythematous, and covered by grayish slough. It's indurated by palpation, okay, and it can occur anywhere, either keratinized or non-keratinized, but preferable sites, soft palate, tonsillar area, and pharynx. Okay, when it's occur on the tongue, it's interfere with its movement. Why? Because it's deep and indurated, so it will make it hard. The soft tissue will become harder. Okay, so in addition to slowly healing process and scar formation that make this complicated condition. And when it occur on uvula, interfere with its mobility, and usually it's a one ulcer, solitary, but occasionally maybe more than one. It heals with a scar, of course, because because it's deep and indurated, and this will take few months, okay, and can be misdiagnosed as squamous cell carcinoma, granulomatous disease such as TB ulcers, or blistering diseases such as pemphigus or mucous membrane pemphigoid or so on. So, what make this major of this ulceration looks like squamous cell carcinoma, for example. First of all, they are sharing solitary or single presentation in duration based on palpation, and duration take few months, and the difference that it will heal, but the squamous cell carcinoma ulcer fail to heal. Copelestone appearance seen at palate due to the recurrent healing with a scar. So it's a recurrent ulcer. So every time this ulcer will occur, the new ulcer will heal with a scar. So this will give a presentation of copelestone appearance. And it may be associated with regional lymphadenopathy and fever in some patients. This is a major aphthous ulcer of the anterior right buccal mucosa and commissure in a patient with advanced AIDS. Herpetiform, the least common variant, multiple tiny pinhead sized, okay, and it's about 1 to 2 millimeter, multiple, maybe dozen, okay, 10th in group, may lead to forming large irregular ulcer, extremely painful and interfere with eating and speaking, and prefer the non-keratinized mucosa, tongue, mouth, floor, and lip, the tongue, the ventral side, of course. Okay, about the healing, it heal quick. Okay, it will heal in a short time, quicker than, of course, major and minor aphthous ulceration. It will take 3 to 4 days as a cycling pattern, but the new group of ulcers overlap the previous one, and there is no interval free time between their remission. Okay, about severe aphthous ulceration, those are recurrent aphthous ulceration. Okay, uh, they are smaller in size, looks like minor aphthous ulceration, but they taking the behavior of major aphthous ulcer. So it is small in size, but it is safe for more than 14 days. Okay. Patients suffer from multiple ulcers any given time, with new lesion developing as existing ones heal. So it will take also the behavior of the herpetiform ulcers, and tip of the tongue from ventral side, um, with a severe recurrent of this ulceration in these patients. Okay, and this is severe recurrent of the stomatitis too. Okay, etiology of the recurrence of the stomatitis. There is no single causative factor has yet been identified, so I can't say this ulcer caused by 1, 2, 3. Okay, there is no single causative factor, and there is no identifiable also causative factor. But we can say there are immunological factors. They are all related to the lymphocytes. Okay, either there is a cell-mediated cytotoxic reaction related to the polymorph nucleus cells or natural killer cells, or there is immunoregulatory imbalance related to T cells. Okay, either T cytotoxic or T helper, and there is a local immune complex reaction related to the complement. Also, there are genetic factors related to the pro-inflammatory cytokines, such as human leukocytes antigen. Okay. At the beginning, we said that Aphthous ulcer may be found related to some disease, so we have to do exclusion. When the Aphthous ulcer presented with another disease, here we are named this condition Aphthous-like ulcer. And this Aphthous-like ulcer found commonly at the hematological deficiencies such as serum iron, folate, and vitamin B12 deficiency. Also related to the celiac disease, autoimmune disease caused by intolerance to gluten, and also related to allergic reaction, either food or drug allergy. Also, it's commonly associated with a Behçet disease and childhood periodic fever syndromes, which is known as FABA, fever, aphthosis, pharyngitis, adenitis syndrome, plus hepatosplenomegaly. Okay, we said this is a recurrent event. So, what makes this recurrence occur? It may be related to hormonal change either by decreased estrogen or high level of progesterone. Emotional factors, which are common trigger factors, stress, exam, and job. Differential diagnosis, as we said, we have to do exclusion. So the exclusion must be from the diseases we said, okay? Iron deficiency anemia, vitamin B12 deficiency, celiac disease, every mentioned in addition to the characteristic or clinical presentation of the ulcer, maybe looks like the viral stomatitis, so we have to differentiate it and distinguish it from primary acute lesions, okay, such as herpes simplex virus 1 primary condition, which is known as primary gingival stomatitis, and chronic multiple lesions such as pemphigoid and pemphigus, especially the pemphigus vulgaris related to the minor Aphthous ulcer, and other conditions like having recurrent ulcers or recurrent events in general, such as connective tissue diseases such as erythema for example, drug reactions, and dermatologic disorders. So to make this exclusion proper, we have to take a proper history and make some investigations, okay, for the patient, taking history about the blood decreases or blood disorders, HIV, connective tissue diseases such as lupus, and gastrointestinal complaints occur, and associated skin or eye, genital, or any rectal lesions. Okay, another thing which is important to do a laboratory investigations and biopsy when necessary. Okay, and then go on by exclude every disease till we reach that oral ulcer is presented without any other sign. So here we are arrived at our diagnosis, which is recurrent Aphthous stomatitis. Okay, how to manage this condition? The management recommended is symptomatic management of Aphthous ulcer. The symptom that the patient complained from it, which is pain. So I want to reduce the pain and accelerate the healing of this ulcerative area. So the management also help in identify the predisposing factor or triggering factor for this recurrent events. Okay. Patient care, dentist care, and doxycycline mouthwash and corticosteroids are management point that we are discussing. Okay. Corticosteroid. If the corticosteroid used during prodrome, so here the patient is facing this problem before. So he's knowing what is a prodrome time. Okay, so during the prodrome, uh, the corticosteroid will be effective. Okay, so it will abort development of ulcer and decrease the duration of the lesion. But if the corticosteroid used in the late stage, where the tissue destruction already progressed, there is no value of the treatment, and the healing will not occur due to the corticosteroid. It will heal. It's a self-limited lesion. It will heal by itself in 10 to 14 days. Okay, starting by corticosteroid in a topical form or using systemic form or intralesional form. Okay, the topical anesthetic agent. Okay, it's important to be used as aura base. The aura base will alleviate the pain and facilitate healing. Okay, we can use paste of benzocaine or lidocaine. It's quite enough for the lesion. Okay, in severe cases, we can use many drugs such as fluocinolone, betamethasone, clopidogrel placed directly on the lesion will shorten the duration and reduce the size of the ulcer. Okay, if the patient having frequent and multiple and painful ulcers, better to give this patient mouthwash and aerosols sprays. Why? To having access to inaccessible areas. Okay, for frequent ulcers, the mouthwash can be prescribed for 2 months as a prophylactic and then stop it for 1 month to assess if the lesion will recur or not. And when we are using corticosteroid for long duration, we have to prescribe for the patient antifungal drugs. Okay, it's very important to be given for 1 week every 4 weeks of steroid treatments. Okay, as a quick recap for the topical, for the mild cases, we are giving only aura base, which is anesthetic topical agent, which is lidocaine or benzocaine. For severe cases, better to give the patient high potency topical corticosteroid preparation such as fluocinolone or betamethasone. Okay, and steroid gel applied after meal before bedtimes, so the patient can use it for 2 to 3 times per day and can be mixed with the aura base if the lesion is very painful. Okay, we have another topical preparations, okay, such as chlorhexidine or topical tetracycline or doxycycline mouthwash. Okay, also it can be available as a paste. Those can be also prescribed for those patients. Okay, for more larger lesions, we can put this paste or gel as prescribed betamethasone, for example, in a gauze sponge and put it or apply it for the lesion and leave it for 15 to 30 minutes. This will allow for longer contact of the medication. About the doxycycline mouthwash, if there is no available mouthwash already made, we can tell the patient or advise the patient to use the capsules and proc 100 milligram into water and use it as a mouthwash for 2 minutes 3 times per day for 2 weeks. And there is a mouthwash based on doxycycline too as a powder. Okay, about the systemic corticosteroid, we will prescribe short duration systemic steroid, and when the topical failed or the lesion didn't heal or with a major ulcer and the drug is prednisolone. 20 to 40 milligram for 5 to 7 days, and then reduce the dose to 10, 20 milligram for few of days. Intralesional. Intralesional, we are using corticosteroid as injected material directly into and around the ulcer. Injection of intralesional steroid of the lesion, which resist healing by topical and systemic treatment for 2 to 6 weeks. The drug we use is triamcinolone acetonide diluted in 0.5 or 1 milliliter sterile water and must be used with lidocaine because the injection of corticosteroid is painful and should be repeated weekly for 2 to 3 times. It's an effective treatment, by the way. Here you can see this is before on the left and after. There is no lesion. You can see here the technique of the injection. Okay, the lesion presented at the A, okay, soft palate, left side, and at the B, the lesion disappeared after treatment with intralesional corticosteroid injections. Okay, dentist care. The dentist should be avoid to use phenol, silver nitrate, because they are delaying healing or make the lesion heal with a scar. And all patients with the recurrent Aphthous ulcers should be advised to avoid food containing benzoate preservatives, potato chips, crisps, chocolate, and highly spiced food, and other irritating substances too. Okay, the herpetiform will not respond to the corticosteroid therapy. So we can use tetracycline mouth bath either containing misticline capsules, tetracycline and nystatin, okay, dissolve in 5 milliliter of water and use as a mouth bath, or misticline syrup, tetracycline and amphotericin, okay. So here we have antibiotic plus antifungal using as a mouth bath. Steroids, as we said, are ineffective in this condition. Thank you.